I am a hematologist at Mayo Clinic in Rochester, obviously a lymphoma specialist. But what may be unique compared to other speakers that you've heard is that my research interest is in survivorship. So, what happens to patients after finishing treatment? I have been the director of our lymphoma survivorship clinic for, 10 years now at least, and have research interest in outcomes, including cardiovascular disease, as well as a significant interest in quality of life and surveillance strategies. So I will go ahead and get started. I am curious to know from the participants, what type of lymphoma have you been affected by, as that may influence what I share or highlight during my talk today, as obviously, there are many, many, many types of lymphoma, and the treatment and surveillance are different. So if you don't mind using just the Q, yes, thank you, the Q&A. I'm seeing, I can see that. I'm just going to look at that for a moment. And I see somebody put in follicular lymphoma. If you don't mind putting in what you want to hear more about, what type of lymphoma. I'll just watch that for a moment before we get started. All right, we've got quite a mix. We've got follicular, mantle cell, Hodgkin lymphoma, CLL or Richter's DLBCL, marginal zone, diffuse large B cell, Waldenstrom's. Okay, great. We've got quite the variety of experiences, anaplastic large cell. Okay, all right, great. Well, I hope to make this useful for all of you. Thank you for your participation. I'm going to move on to my next slide. I don't have any financial disclosures, and our learning objectives are to talk about surveillance and including some long-term survivorship issues, and look at the recommendations. This says Hodgkin lymphoma survivors. Really, this applies to all lymphoma survivors. So first, let's talk about surveillance, and I need to give you some definitions here. So when I think about surveillance, I am talking about what we do for following you after you have completed your therapy, your primary therapy. Or let's say that you have follicular lymphoma, for example, and you're being observed. How do we follow you with the intention of understanding the state of the lymphoma itself? So I'll give an example for those who have an aggressive lymphoma, such as Hodgkin lymphoma or diffuse large B-cell lymphoma, where our upfront therapy goal is cure. So at the end of treatment, let's say you got R-CHOP, 6 cycles, and then had a PET scan, and at the end that showed that you were in complete remission. That scan is not considered your surveillance. That is end of treatment scan. So any scan after that, when you're in remission, would be considered a surveillance scan. Okay. What we know for those with aggressive lymphomas, where the upfront therapy intention is cure. So that's diffuse large B-cell lymphoma, that is Burkitt lymphoma, that is Hodgkin lymphoma. We have plenty of data showing that scans in complete remission when the absence of symptoms are not necessary. So let me repeat that. In aggressive lymphomas, in a complete remission, a scan with the absence of symptoms is not necessary. It does not change outcomes. So this data is from a cohort of patients with Hodgkin lymphoma. And you can see there's 2 different lines here. One is blue, one is greenish, and they're from 2 different groups. One group was treated at a cancer center, well-known lymphoma group, fantastic group, and their practice was to not do any scans in surveillance. So if somebody's in remission, they're feeling well, no scans are necessary. The other group was from I think, 3 separate cancer centers, all well-known, great lymphoma centers, where their practice was to do surveillance scans, even in the absence of symptoms, on, let's say, an every 4-month basis or so, during that first few years following treatment. They then looked at what's really important in cancer, which is overall survival, and found that these lines completely overlap. And so what we know, and this is a Hodgkin lymphoma group, but this has been shown in diffuse large B-cell lymphoma. It's been shown in aggressive T-cell lymphomas. And actually, we've looked at the value of surveillance scans in follicular lymphoma as well. And there does not seem to be any improvement in outcomes in doing a scan in the absence of symptoms. Therefore, I'm a real fan of minimizing scans if somebody's feeling well. And why? Well, there's a lot of downsides of doing imaging. I list 3 here that I'll talk about in a little more detail. First of all is radiation exposure. Secondly is having false positives, and I'll talk about what that means. And then third is anxiety. Fourth one that I don't include here, and I really should have, is cost. Okay, of course, nothing comes for free. All right, radiation exposure. All imaging, I shouldn't say all imaging, all CT imaging, all PET imaging, all X-rays expose individuals to radiation. You can see in this graph or this table the doses of radiation. When we're thinking about lymphoma imaging, we're usually doing CT of the chest, abdomen, and pelvis. So the radiation dose is listed at 2 to 10. If you do all 3, it's going to be, multiply that by 3. So 6 to 30. PET scans are a little bit less than this. They have a CT component, but the CT is less fine data, so it's a little bit less. Let's compare that to the background radiation dose that we all receive just from living on Earth, and that's about 3 per year. So when we're adding a scan in here, we're definitely increasing the radiation dose. And let's say that you may have scans every couple times a year. Those do add up over time. What's the problem with radiation? Well, radiation has a theoretical exposure or a theoretical risk of increasing the risk of getting a secondary malignancy. So for the data, which is theoretical again, shows that for those who are of, I'll say, more mature ages, mature meaning, over age 50 or so, because these doses are low and because radiation risk in terms of causing that secondary malignancy is not an immediate risk. It's something that happens years and years and decades down the road. This probably is a theoretical concern that really is not clinically relevant. But it is important for those who are younger. So those who, let's say, were affected by Hodgkin lymphoma in their 20s, if we're talking about additional radiation exposure during those younger years, and an individual has decades ahead of them of life, as we hope, because that's the goal of therapy, then this risk really may be more than just theoretical. It may be an increased risk of secondary malignancies. So something to consider. Definitely in terms of why not to do frequent scans in the absence of symptoms. Another really important topic is false positives. And this gets back to, why are we doing a scan? Well, we want to make sure the lymphoma hasn't come back, right? However, scans are pretty sensitive. And this study looked at, this was called a meta-analysis. So it looked at a series of about 10 different studies and put all that information together, looking at the risk of a PET scan in lymphoma survivors, in finding something on the scan that was called as an area of concern, but then ended up not being a lymphoma relapse. look at how often this happens. 43% of these abnormalities are actually false positives. It's a clinical concern that oftentimes then leads to more scans, more biopsies, and of course, a heck of a lot more anxiety, cost, risk of getting a biopsy, of course, that turns out to be nothing of concern. What are these things that cause these false positives? Other causes of lymph nodes that may light up on a PET scan. Anything that causes inflammation, whether that be infection, or sometimes people have a rheumatological condition, will cause some increased activity within those lymph nodes. That's what our immune system is supposed to be doing, and therefore it's not lymphoma. Sarcoidosis, which is a not very common disorder, but it's an inflammatory disorder. It's certainly one that we pick up quite a bit when we're following our patients with lymphoma. Thymic hyperplasia is, again, a phenomenon of our immune system doing exactly what it's supposed to be doing. Chemotherapy or other intensive treatments cause suppression of our immune system. We know that certainly that leads to increased risk of infection, et cetera. But one of the things that we'll see in recovery from that immune system suppression is that the thymus gland, which sits in our neck and normally is really active during childhood and adolescence in populating our immune system. But then during early adulthood and into adulthood becomes pretty small and doesn't have a lot of activity. It really lives its best life during our early years. However, if our immune system is wiped out from chemotherapy or transplant, it can become reactivated as the immune system is repopulating. One great example is for those who have had bone marrow transplants, you know that afterwards you get all of these vaccines to teach your immune system some memory again against common childhood and adult diseases. Well, that requires your immune system to recognize those vaccines and then develop a memory around them. A lot of that happens in the thymus gland. So if we do an image of the PET scan, we may see that thymus gland that's normally really small and doesn't, not active during adulthood. It may become larger, and because of the activity, may become PET positive, because it sits right next to a whole bunch of lymph nodes, and it can look like a mass in the mediastinum, just like lymph nodes. Oftentimes, it'll be called positive on PET scan. And then lastly, fibrosis, which is the medical term for scar tissue. We can find that certainly on a PET scan. So again, almost half of the time that we're doing a PET scan in surveillance for lymphoma, we're going to find something that's going to require further follow-up that is not lymphoma. All right. Next thing is anxiety. And I'm kind of preaching to the choir here, and I'd be curious to know how many of you have experienced anxiety around the time of follow-up scans. If I had you raise your hands, I imagine the majority of you would. And this has been studied in the literature. This comes from a study of cancer survivors, not limited to lymphoma, but lymphoma patients were represented. And they were asked, what's your biggest concern following or during the time of surveillance? So you can see here, a good third of individuals have significant concerns: fear of recurrence, concern that a symptom indicated a recurrence, fear of developing another malignancy. But look at that on the bottom, future diagnostic tests. Over a third, almost a half of patients have concerns about future diagnostic tests. And so I think it's really important for us as physicians to understand that scans do produce significant anxiety and decrease quality of life. And potentially for all of these reasons I talked about: radiation exposure, what leads to maybe more testing and turns out not to be a recurrence of cancer. All of these things, the cost of it. I know I've some patients who have really bad veins after going through all that chemotherapy, and just getting the IV put in can be traumatic. Or just going back to that site where you had that initial diagnosis and going through testing and had other diagnostic tests can bring back a lot of those negative emotions. So certainly something to be aware of. And then we did do a deeper dive into this in lymphoma survivors. I interviewed 70 lymphoma survivors who were in complete remission. These were survivors who are out about 5 years on average from the time of their diagnosis, although we had some that were as far out as 38 years, so long-term survivors. This was a mix of individuals with all sorts of different lymphomas, just like my audience today. So I did a anxiety questionnaire that's a standardized questionnaire asking about current symptoms. And 38% of individuals reported clinically significant anxiety. And again, this is 5 years out from treatment. To learn more about what was the cause of anxiety, because my feeling was this is not anxiety that's like, going into social groups, or, this isn't like a global anxiety. I wanted to hear more about what was the specific anxiety. And sure enough, what I found when I interviewed then the 70 patients and asked open-ended questions, found that most of the anxiety really was around the time of these follow-up visits, particularly if there was a surveillance scan associated. What people described to me was feeling fine most of the time, but about 2, maybe 3 weeks before that follow-up visit, anxiety started to build. And if I was ever interviewing somebody with their significant other, the significant other would say, "Oh, I know. I don't even have to look at the calendar to know when that next follow-up visit is, because I can tell from the difference in behavior because of that anxiety." And that anxiety builds and builds and builds, and then peaks before the scan and is at its highest level at the time during that visit when you're waiting for the results. As soon as the results come back in, then it's like a balloon has been popped. And then the anxiety goes back down. And feels pretty good. Sorry, I just was trying to look at the questions in the chat as they were coming in, and I'm messing up my slides. And so that anxiety then goes back to like very, very, very low levels. So that is a pattern that gets repeated. And so the question is, how should we monitor patients in complete remission? And I see somebody ask this in the question as well. So this applies to those with aggressive lymphoma. When we looked at a cohort of survivors with diffuse large B-cell lymphoma at the time of relapse, MER is an American cohort with patients from Mayo Clinic and University of Iowa. Lyon is in France. So we looked internationally. The majority of patients had symptoms. Almost half of patients had an abnormal physical exam documented. About half of patients had an abnormal lab test. And if we looked at those who had at least one of those features, about 90% had at least one feature. And therefore, what we recommend is, in the absence of symptoms or physical exam or abnormal labs, no scan is necessary. However, we need to be, as physicians, very, very cognizant of making sure we get a really good history from patients when they come into visits. How are you feeling? Have you had any swollen lymph nodes? Any abnormal weight loss? Have you had drenching night sweats? Any new pain, for example, or any fevers without a clear reason why. Those are the symptoms that we look for. A good physical exam, including looking, palpating all those lymph node regions, and then looking at the the laboratory studies. And if none of those features are present, the chances of missing a relapse of an aggressive lymphoma is very low. Now, I sometimes get the question, I see somebody put it in the chat, well, I was stage 4 when I got a diagnosis, and without symptoms, how would a recurrence be detected without a scan? Well, it really depends on the type of lymphoma that we're talking about. If this is an indolent lymphoma, then that's true. It may be that indolent lymphomas may be growing and we wouldn't know without a scan. However, and I'm not against scans. I think there are sometimes good reason in the absence of symptoms for those with, let's say, an indolent follicular lymphoma to do intermittent surveillance scans. However, minimize them. This does not need to be every 3 months or 4 months or even every 6 months, as long as you have a trend that things aren't changing rapidly. And the nodes that are enlarged are not in an area that is of significant clinical concern, meaning it's not too close to, for example, the ureters, the tube that drains the urine from the kidneys to the bladder. We know that if the lymph nodes are really enlarged in that area, then it can kink off that tube and cause kidney damage. We don't want that. But there's a lot of space in the body where lymph nodes can grow and not cause any clinical concerns and not any clinical symptoms. So checking a scan on an annual basis or even every 2 years for those that are growing really slowly is a much better strategy than checking on a more frequent basis because of these other things, other risks that I mentioned. And yes, I know that some people do feel anxiety feel less anxious when you get an all clear scan. It's a double-edged sword. I agree. But I will also say that and I've had colleagues say this as well, like, or maybe I'm going to pick up something else that's meaningful. Like, gosh, I remember one patient where I picked up a different kind of cancer and saved their lives. Yes, that is true. When you do enough scans, you will pick up some things. However, that kind of makes the same argument. Why don't we just have CT scans in shopping malls and scan everybody, because of the off chance that we might find that one in, a gazillion things like that. And that's just not a good proper use of healthcare resources, cost, radiation exposure, or anxiety. Somebody asked a question here in the chat about elevated LDH. Oh, LDH by itself is not a great surveillance lab at all. I don't have the data shared on these slides, but there is multiple studies that show that an elevated LDH with nothing else does not predict for relapse of lymphoma. And in fact, I struggle with if I should even check LDH during surveillance, knowing it's basically a flip of the coin because it's not specific to lymphoma as well. In fact, the lab was developed to show cardiac damage after a heart attack. It's very nonspecific for any kind of cellular damage or cell turnover. So doing exercise before getting your labs drawn, if you do heavy exercise, weightlifting, for example, and you've got a little muscle tears that happen, which is normal part of how we build muscle, your LDH is going to be elevated. If you have an infection, for example, let's say you caught COVID, your LDH is going to be elevated in the setting of infection. So it's so non-specific. Also, there are patients who have a low LDH as their normal. I have one patient who had diffuse large B-cell lymphoma. He had a couple of relapses along the way. His LDH was never elevated during a relapse, but when it got close to 150, normal being 222 and above in our, or abnormal being 222 and above in our lab, when it got above 150, which is well within the normal range, that's when I knew I was concerned for him. And on the other side, I have multiple patients whose normal LDH is in the high range, because the way our labs are designed is statistically the normal range fits 95% of the population, which means 5% of the population will have their normal range being outside of that. So it's trend over time, not a one-time thing. All right. And then I have I see lots of different questions. I'm going to move on, and I think I'll answer some of these during my rest of the presentation. And what I don't get to, I will come back to during question and answers. All right, late effects. I'd like to talk about this a little bit. So this is getting beyond the lymphoma coming back. This is talking about what do cancer survivors die of. So, and this is not lymphoma survivors. This is all comers of cancer. And so majority of those who have a diagnosis of cancer will die of their cancer. Remember, I'm talking about lung cancer, breast cancer, prostate cancer, colon cancer, etc. But look at these other causes: heart disease, lung disease, and others. So we really need to be aware of risks of other diseases in our lymphoma survivors. And because some of our treatments will cause increase in these late effects, including cardiovascular disease. One of the chemotherapy drugs that is commonly given for those with aggressive lymphomas is doxorubicin, or other name is adriamycin. It is the red drug, the one that looks red in the IV. We do know that this drug in large doses can cause damage to the heart muscle itself. The other thing that causes damage to the heart is radiation. It has to be radiation that is delivered to the heart itself. If you got radiation of your arm, for example, for a lymphoma nodule there, that does not hit the heart, and that does not increase the risk of cardiovascular disease. So it's radiation to the chest primarily. This image is radiation fields, as they're called. All those dotted areas are areas that we used to treat with radiation in something called a mantle field. This was really common back in the 1970s, 80s, even into the early 90s for Hodgkin lymphoma. And as you can imagine, that definitely did hit the heart. We also used to use much higher doses of radiation, and our radiation techniques were not as sophisticated as they are now, where there was more scatter of the beam, and so we hit more abnormal or more normal structures, I should say, heart, lungs, etc., than certainly in today's era. So what is the risk of cardiovascular disease in lymphoma survivors? This study looked at Hodgkin lymphoma survivors because that mantle radiation was most commonly used in Hodgkin lymphoma survivors. So first thing to notice on this graph, which is the cumulative incidence of developing cardiovascular disease over time, 0% is the bottom, and then as we go up on the percentage, and the y-axis is more. You can see that this does not happen early. This is something that is a risk 10, 15, 20, 25 years after treatment. It's something that takes time. Highest risk is getting that mediastinal or chest radiation and anthracyclines, which is the adriamycin. Next step in terms of risk would be mediastinal radiation without anthracyclines, then anthracyclines. And then the bottom line here is just having the risk of cardiovascular disease, probably unrelated to the lymphoma therapy, as we know that many individuals have other risk factors such as hypertension, high cholesterol, smoking, family history, those other things. But definitely lymphoma treatment does increase that risk. What's the likelihood of getting cardiovascular disease from that adriamycin or doxorubicin? It happens at very high doses that we generally don't give in lymphoma. We cap at somewhere around 350 of our cumulative dose here. But what adriamycin or doxorubicin does is increase the risk of congestive heart failure, not of other types of cardiac disease. So now that we know this, you can see this data is old. This is 2006. That's one of the reasons that we cap that dose. And also for those who have underlying cardiovascular disease, meaning on echocardiogram, the ejection fraction is lower than we'd like to see at baseline, then we don't even give adriamycin. All right, again, coronary artery disease happens late, and this is a risk that happens primarily due to radiation, not due to chemotherapy. The higher the dose, the higher the risk. So what are the screening recommendations for those who received radiation to the chest? If it was 30 gray or higher, so you have to know the dose, then we do recommend doing stress tests, which we at Mayo do as an exercise stress test, starting 5 to 10 years after treatment. And I do 10 years unless somebody has symptoms, and then every 5 years. For those who did not get radiation but got chemotherapy with adriamycin at the dose of 240 or higher, we do an echocardiogram within 12 months of treatment. And then if it's normal and we don't see any evidence of damage, then it doesn't need to be repeated. It's just a one and done. And then obviously if symptoms develop, then an echocardiogram down the road would be helpful. We know that the traditional cardiovascular risk factors are additive to the lymphoma treatment risk factors. And so having an annual physical exam with your primary care physician to check blood pressure, check the cholesterol, and then check sugar levels as well. And one thing about the glucose or sugar levels is there is an increased risk of type 2 diabetes from lymphoma treatment itself if the pancreas, which creates all the insulin, has been radiated, which is in the upper abdomen. And then we recommend treatment of those cardiovascular risk factors with particular medications. So there's a couple different blood pressure medicines that do have a protective effect from the heart that aren't always the first line for high blood pressure. So what I do is I always send my primary care physician colleagues a summary of the treatment and recommendations saying, hey, if this patient, if Mr. Smith gets high blood pressure, please use a beta blocker or ACE inhibitor as opposed to another blood pressure medication because they have had anthracyclines in their past. And then lifestyle modifications, which we'll talk about in more detail. This is data from, again, Hodgkin lymphoma survivors. We study Hodgkin lymphoma survivors for survivorship issues in lymphoma patients quite a bit because patients tend to be diagnosed early in life, and it's a very curable lymphoma. So patients do live for many decades afterwards. And also patients did receive, again, pretty high doses of radiation in decades past. What we know, this study looked at survivors of Hodgkin lymphoma and asked them, how much exercise are you doing? And exercise is measured in METs. So if those who are doing more METs per week, that's the blue line, the yellow line is those doing greater than or equal to 9 METs per week versus those less. So those doing more exercise regularly have a lower risk of developing any kind of cardiovascular event. And when we look at what type of cardiovascular event, it's not just coronary artery disease, but heart failure and valve replacement. So being physically active is a really important part of staying healthy after any kind of lymphoma. Besides heart disease, we've done studies in Hodgkin lymphoma survivors looking at how active individuals are, and have found that those who meet the criteria from ACS, which is American Cancer Society, of physical activity guidelines, those who meet the guidelines versus those who don't, have a lower risk of death due to lymphoma itself. So let me repeat that let me turn it around and say the statement a different way. we have reason to believe that those who are more physically active after lymphoma treatment have a lower risk of lymphoma coming back and lymphoma taking that person's life. And we saw this also, not just those who were, let's say, athletes when they got lymphoma, they're the regular exercisers already. We saw this in people who increased their physical activity after lymphoma because they made lifestyle changes. So even those who were not physically active but then became physically active enjoyed the same benefit. And it was much worse in those who decrease their physical activity after lymphoma diagnosis. So either remaining active or increasing activity has excellent benefit during surveillance time. I love this photo because it reminds me that I don't need to be counseling my patients to start running marathons. It starts with it starts where you are. And this lady, who is just adorable, is probably not running marathons. Maybe she is. I want to give her credit, but she probably isn't. But she's doing what she can. She's doing some 1 or maybe 2 pound weights there and staying active with exercise that is reasonable for where you're at. Most of the intervention studies of exercise in cancer survivors are using a walking program. They are not using something that is like a marathon or a triathlon. It is just walking. And so working up to walking or whatever exercise you enjoy, anything that you feel your heart rate is going up, to do 30 minutes most days of the week. Goal is 5 out of 7 days. So find that time, work up, find an exercise buddy. This picture is also to remind me to share that there's many programs at YMCAs across the country called Live Strong that are specifically for cancer survivors that are free exercise programs. Many cancer centers have exercise rehab programs for cancer survivors as well. And then there's other programs like YMCA has Silver Sneakers programs, and some insurance companies give some great benefits too to healthcare gym facilities and such. So I highly recommend being physically active for all of my patients because there's benefits for cardiovascular disease, including mitigating some of that risk that you may have been increased because of the lymphoma treatment, as well as the association between increased survival from lymphoma should it ever come back. All right. Now, a question about diet. I get this question a lot. And I saw in the Q&A, there were a few questions already. What should I eat now that I've had lymphoma? Excellent question. And it's one that's really hard to study from a research standpoint. There are no studies that I'm aware of that specifically looks at this question in lymphoma survivors. This study, however, was in individuals who were part of the general population, and they looked at a Mediterranean diet versus usual American diet, which we know is nicknamed SAD because it is sad, but it's also standard American diet, and followed patients for cardiovascular disease. And you can see that those who had the controlled diet, aka SAD diet, had a higher risk of cardiovascular disease versus those who had a Mediterranean diet. And they had a couple different versions of that, one that ate more nuts versus EVO, which is olive oil. Those were pretty similar. So what I recommend is my patients to follow the guidelines of a Mediterranean diet, which is, oops, sorry, I thought I had a nice slide showing what it is. I'll tell you what it is. It is rich in plant-based foods, fruits and vegetables. And fats come from, again, nuts and olive oil. Meats are allowed, but infrequently. Poultry and fish are preferred as protein sources, as well as protein from plant-based foods. This is Mediterranean, so red wine is considered part of that diet in moderation, and it's not a must for those who are do not consume alcohol. It's not recommended to start. And what about sweets? What about, an occasional piece of cake? For example, have the pleasure of hosting a Halloween party this evening for my children who are in middle school, and we're going to be making some treats, including a cake, as soon as I'm done with this Zoom meeting. Absolutely, you can indulge in sweets every now and again. It's moderation. Okay. And I also think the biggest part of this is how do you make those changes? Start by eliminating or decreasing processed foods. Try to make everything yourself. So purchasing a cake versus making it yourself. You know where the ingredients came from, and you're less likely to have some of these chemicals that are added to food, such as high fructose corn syrup, or versus having a candy bar, which is processed with all sorts of terrible things. Having sweets that you make yourself for those things in moderation. Okay, there's zero evidence that having a diet that eliminates all sugars has any benefit for decreasing the risk of lymphoma or treatment. All cells require sugar in order to function, and therefore anything that's really restrictive, I don't recommend. Mediterranean diet is my recommendation. All right, what about loss of immunity? We know that chemotherapy and radiation causes a decrease in our immune system. And so there are some specific recommendations during the surveillance period related to vaccines. One is that you should not have any live vaccines. Vaccines come in a couple different varieties in terms of how they're made. This pertains to the influenza vaccine, as the flu mist that goes through the nose is a live vaccine that should be avoided if you've had lymphoma in treatment. But the flu shot is inactivated and therefore completely safe and is recommended on an annual basis. If you have not had it yet this year, highly recommend that you get it as soon as possible, as it is predicted that we're going to have a much worse flu season this year. In terms of the shingles vaccine, there is Zostavax, which is a live vaccine that is not recommended. And thankfully, it's hardly ever used anymore, as Shingrix, the current recommendation, is not just inactivated, but also has a much higher protection against shingles. Don't forget about that tetanus shot. For those who are younger, the HPV vaccine. Younger means less than age 26, but even up to age 45, it's recommended to have a conversation with your healthcare provider if you're eligible. Anyone who's had a history of lymphoma up to age 45, I recommend it. And then pneumococcal vaccine, even if you're younger than the typical age that it's recommended to get pneumococcal, if you've had lymphoma, we recommend getting this, which is a 2-series shot, the PCV in 13 and 26. Unfortunately, we know that the vaccines are not as effective for those who have heme malignancies, in particular if you're on active treatment. So we recommend getting the vaccines either before starting therapy and then having at least 2 weeks delay before starting treatment if you have the privilege of waiting, or waiting until after you have completed therapy. Now, let's say, gosh, I'm in the midst of RCHOP therapy right now, and you just told me flu season is worse. And as I'm looking at this graph on the right, it doesn't look like it has much of effectiveness at all. Should I even bother? Our answer is yes, because the way that this is measured, we don't know if there's some other effectiveness in terms of T cell memory and such. And even if somebody is to get flu, it probably decreases, or it does decrease the severity of the infection. What about the COVID vaccine? This data shows why 3 doses are recommended for those with heme malignancies. This is actually in lymphoma patients, as opposed to 2 doses at for that induction. So we do recommend that 3 series dose at to start, and then the boosters, if you haven't gotten those yet. It does decrease the severity of COVID, and I've lost too many patients with heme malignancies due to COVID to have a debate on this. Unfortunately, we know that those who are on anti-CD20 therapies such as rituximab, those on CAR T, or those on BTK inhibitors such as ibrutinib and others have less efficacy from COVID vaccines. All right, secondary malignancies, I'll touch on here. We do know that chemotherapy and radiation are carcinogenic, meaning that they do increase the risk of developing other cancers. 16% of all new cancer patients are in those who have had a cancer in the past. And some of this is due to the chemo and radiation, but some is just due to genetics, like those with breast cancer and a BRCA mutation, for example, lifestyle factors such as smoking and other environmental exposures. So I'm going to go right on to recommendations for those at risk. If you've had radiation, it increases the risk of skin cancer. So having an annual skin exam is, in particular in the area of that you've had radiation, is important. For women who have had excuse me, somebody let the dog in. Let me mute myself for 1 second and yell at my family to take the dog out. Somebody get Maisie right now. Sorry about that. Okay, so for women who receive chest radiation, during their early ages, meaning between ages 15 and 35, do have an increased risk of breast cancer and therefore need not just an annual mammogram, but also an annual breast MRI. And that should start at age 40 or 8 years after treatment. All right. Colonoscopy for those who have had radiation to the pelvis, abdomen, or spine should start sooner than age appropriate. Which age appropriate, reminder, did change. So the regular colon cancer screening should start at age 45 now, not age 50. And then of course, tobacco cessation and lifelong surveillance. All right. Some of this definitely is scary, but I want to tell you that our treatments have gotten better with time. I've talked about that with radiation, and chemotherapy has certainly changed. And if we look at the data according to causes of death from non-lymphoma, and this is actually childhood cancer survivors, so it's not just lymphoma. These individuals also had other cancers like sarcoma and acute leukemias. We can see that the health-related causes, which oftentimes those are the things we attribute to the chemo and radiation, that has really decreased over time. And this is data up to the 1990s. So we know that the 2000s and 2010s is going to be even lower. So thankfully, our treatments have improved. All right, I want to round things up by talking about quality of life, which is really important. Depression and anxiety are common issues that do occur around the time of a cancer diagnosis. The data shows, though, that depression does not persist. It is higher than general population for about 2 years and then is similar to rates of general population. Anxiety is a different story. And I think with the anxiety data I shared related to scans, a lot of this is related to the risk of the concern of relapse and all the follow-up that's necessary. And this anxiety is not just related to does not just affect the patient. I saw somebody put this in a Q&A already, that anecdotally anxiety happens in caregivers. And here's data that supports that. Absolutely. Anxiety is higher in spouses in this particular study as well. And I dare say sometimes higher because of the different lived experience. Again, it's not all bad. We followed long-term quality of life in survivors of aggressive lymphoma and showed that quality of life is actually better than the general population over time. And why is that? Because I think you can all think of in your own personal experience that there are silver linings in getting a diagnosis of cancer and finding meaning and finding new supports and such. So that was a whirlwind view of now that I've in remission, what do I do? What do I do for surveillance? What lifestyle changes should I make? What other kind of surveillance should I have besides scans, things like echocardiograms, mammograms, colonoscopies, et cetera. And I know there's a number of questions which I will attempt to answer. We have about 10 minutes for question and answer. So I will take a look at these questions. All right. Some questions on vaccines. So post-R-CHOP, are old vaccines still effective? The short answer is yes, generally. It's only after transplant where we recommend repeating all of those childhood vaccines. How long should you wait after finishing treatment after rituximab or other treatments to get the flu vaccine or other vaccines? Generally, it takes about 6 months. We recommend, if possible, to wait that long to allow the immune system to recover. However, if it's in the midst of flu season, I recommend just getting that flu vaccine earlier as opposed to waiting. Do I have information on cannabis and immunosuppression? No, I don't. Significance of uric acid levels in routine follow-up in follicular lymphoma. Uric acid levels are related to many, many different things besides lymphoma. Uric acid can be increased in individuals with either a little bit of renal dysfunction, kidney issues, or just some people make more uric acid than others. That's common in the general population, probably has nothing to do with the lymphoma itself. Can exercise and diet help mitigate effects of treatment? Absolutely. I showed that data of those with mediastinal radiation who have significant risk of cardiovascular disease from treatment, and following exercise regimen definitely does mitigate that risk. All right, so a lot of questions about indolent lymphoma, and do these recommendations pertain to those with indolent lymphoma as well? I would say the vast majority, yes. Everything I talked about in terms of vaccines, everything I talked about with risk of secondary malignancies, the cardiovascular disease and such, but you really have to know your treatment. So knowing your treatment, meaning, did you get anthracyclines? If you had radiation, what was the dose and where was it? Those things are going to really be pertinent to what your surveillance should be. In terms of the frequency of scans and when to get them, it has to be individualized according to where your disease was and the comfort between you and your lymphoma provider. My recommendation is not to get PET scans in surveillance, no matter what your lymphoma was. There's overwhelming evidence that PET scans have too many false positives in surveillance and should never be used unless there are symptoms and there's a concern for relapse. If you are somebody who's getting intermittent surveillance with an indolent lymphoma or a mantle cell lymphoma, et cetera, and you're having them at infrequent intervals, it should be a CT scan, not a PET scan. And again, I just challenge, I think I think a lot of scans fall into the category of doing things for no reason, that we sometimes do in medicine, and our evidence is showing more and more that we do too many scans. And there's reasons why not, that hopefully I shared they don't improve outcomes, and at least in aggressive lymphomas, but we've shown it in follicular lymphoma as well. So even minimizing those scans, is helpful. When should you remove your port? Oh, that's a great question. I don't think it's worth keeping just in case, because having a port in increases the risk of infection and blood clots. So I think certainly once you're done with treatment, having it removed is a good idea. And sometimes people like to wait for maybe to get to that 6-month mark. I think that's okay. Beyond that, then I think we don't want to keep that as kind of as a security blanket, because we don't want a security blanket to turn into a pulmonary embolism. Let's see. Thank you. Somebody said a nice thank you. I'd like to say thank you for the thank you. And let's see, what other questions? I'm sorry, Mark, I know you're helping me and I'm going up and down here. So what's the role of MRD testing in lieu of imaging? Gosh, that's a great question. We're getting more and more information on that. And I think for those with mantle cell lymphoma, it makes sense to include that as part of surveillance. And again, that should be individualized with your hematologist. All right. And I think I'll take a couple of questions here towards the end. What percentage of lymphoma patients get secondary cancers years later? It's about 16% we know of on average. And many of those are unrelated, where somebody had lymphoma and just happens to get a breast cancer years later. That's probably bad luck as opposed to anything related to the treatment itself. But we do know that once you've had one lymphoma, certainly there's a risk of developing a second lymphoma later in life, and it may be a different kind of lymphoma, although that risk is in the couple percentage points, pretty small. However, I tell everyone that risk just to be aware of. We don't recommend doing intermittent scans for that or anything like that, but just to be aware of what are those symptoms. So think about, oh yeah, from when I was diagnosed, I remember I had those drenching night sweats. Well, that keys you in. Okay, that's something to watch for. Or new lymph nodes that you can feel that haven't gone away over time, unexplained fevers, unexplained weight loss, or pain that seems unusual. Those are all things to be aware of. More questions about MRD. I'd refer you probably to talk to your lymphoma physician if you have specific questions related to your disease. It stands for minimal residual disease, and there's tests available for certain lymphomas, not all lymphomas. It's a minimal number, and some of those tests are done on bone marrow biopsies, and some are done on blood work.